The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/KNX860. Downloadable slides and practice aids are also available.
Hello, and welcome to the Path Forward for Immunotherapy and Resectable Melanoma, Principles and Perspectives on Using Immune-Based Adjuvant and Neoadjuvant Therapy. I'm Jennifer Wargo from the MD Anderson Cancer Center in Houston, and I'm joined today by Charlotte Arian from Memorial Sloan Kettering Cancer Center in New York, and Lex Egermont from Princess Máxima Center for Pediatric Oncology in the Netherlands. And for today's agenda, we have several key parts. First, we'll have an introduction on the evidence to date on adjuvant and neoadjuvant immunotherapy. And secondly, we'll have clinical consult sessions where we'll do case discussions on the principles and practice of using immunotherapy in resectable melanoma. And so as our first speaker today, I'd like to welcome Dr. Alexander Egermont, who will speak to us today about optimized adjuvant immunotherapy and development of neoadjuvant treatment. Lex.
Thank you, Dr. Wargo, and good day. And let's look at an update on the adjuvant therapies that are currently approved and the development of neoadjuvant therapies. So I'll give that update, and I'll deal with what is next in adjuvant therapy trials that are actually ongoing. And then I'll finish off with the neoadjuvant immunotherapy revolution and what we can expect from that particular development. So we know we had an old era in the adjuvant therapy story of melanoma, and it was an interferon alpha story with, by and large, marginal effects. And at a time where there were no effective treatments for the advanced melanoma setting. Now, since 2015, we have approved adjuvant therapies as a result of effective drugs in the advanced melanoma setting. And consistency of data led to the fact that the first drugs that were approved in the advanced setting all were approved also in the adjuvant setting for stage 3 disease. So it started with ipilimumab, the EORTC 18071 trial, and it led to FDA approval in a trial that was in stage 3 melanoma, ipilimumab versus placebo, and you see the hazard ratio. Then not before long, it was demonstrated that nivolumab, just like in the advanced setting, was also in the adjuvant setting superior to adjuvant ipilimumab. That was the Checkmate 238 trial, and it led to FDA approval in 2017. For BRAF mutant melanoma patients, there is another opportunity, and that is a BRAF-MEK combination. And dabrafenib plus trametinib was demonstrated in the COMBI-AD trial to be superior to placebo in stage 3 melanoma, with a hazard ratio as indicated, and approval was following in 2018. And the other anti-PD-1 molecule, pembrolizumab, was also tested in stage 3 melanoma versus placebo, and was approved in 2019. So that's the current status of affairs. So EORTC 18071 trial, ipilimumab versus placebo, already now has mature long-term data. And the important observation is that there is a direct and consistent benefit for all the endpoints: relapse-free survival, distant metastasis-free survival, and overall survival. By and large, you see at long-term absolute benefit, a 10% difference between the upper curves, ipilimumab, versus the lower curves, placebo. You see that the hazard ratios are the same for all these endpoints. But the problem with this trial was that the ipilimumab at a dose of 10 milligrams per kg brought a lot of toxicity. And so there was a 54% discontinuation rate in this trial. For the BRAF mutant melanoma patient population, the most mature data are the ones of the COMBI-AD trial, dabrafenib plus trametinib. So remember, the immune therapy adjuvant trials are valid for all melanoma patients. This is only valid for BRAF mutant melanoma patients. So in this trial, dabrafenib plus trametinib was randomized against a double placebo, and the 3-year, 4-year, and 5-year results were just published in the New England Journal of Medicine. And you see that in terms of absolute differences, there's 20%, 17%, and 16% rate differences at 3, 4, and 5 years for relapse-free survival. And it does translate in distant metastasis-free survival benefits, somewhat smaller, 14% differences at 3 years, and then 8 and 7% differences at 4 and 5 years. Regarding the CheckMate 238 trial, nivolumab versus ipilimumab in stage 3 BC and resected stage 4 patients, an update was just published in Lancet Oncology in November last year. And in this trial, nivolumab was randomized at its usual dose versus ipilimumab at the high dose, because that was the approved ipilimumab adjuvant therapy dose. And here are the curves. You see for the primary endpoint, relapse-free survival, you see 3 and 4 year data indicated. The top curve is nivolumab, and the bottom curve is effective adjuvant therapy with ipilimumab, and the differences are 14% and 11% in absolute terms at 3 and 4 years. Does it translate into distant metastasis-free survival benefits? Yes, it does, but the differences are clearly smaller, and they are in the order of 8% and 6% at 3 and at 4 years. But there's great consistency in all the data flow so far. They did an exploratory analysis on overall survival, but far away from the required event-driven analysis for a final analysis for overall survival. What it shows is that the impact of salvage treatments, once you are diagnosed with distant metastatic disease, actually closes the gap between nivolumab and ipilimumab, and you now have overlapping curves. The other trial is anti-PD-1, pembrolizumab, versus placebo in stage 3 melanoma patients, the Keynote 54 trial. And here you see a specific element in the trial design that is, however, very important. So randomize pembrolizumab 200 milligrams flat dose every 3 weeks for a year versus placebo. But once you have a relapse, the patient is unblinded. And if it was a placebo patient, it always gets offered for free the trial medication, pembrolizumab, for up to 2 years, now with distant metastatic disease, usually. If the patient recurred after more than 6 months after having completed adjuvant pembrolizumab, then he would get that same offer. This crossover design, therefore, allows us to formally analyze the question, do you actually need to offer adjuvant anti-PD-1 to all patients right after surgery for stage 3 disease, or would the result be basically the same if you only treat those who relapse and then immediately start treating them with anti-PD-1 at the time of relapse? So a very courageous design, and the only trial with a formal crossover design. So for the primary endpoint, relapse-free survival, you see a very clear benefit of pembrolizumab, and it, in terms of 2 years and 3 years relapse-free survival data, you see an absolute benefit of about 20%. Hazard ratio is 0.56. Does it matter if you have PD-L1 positive or negative disease? No, it doesn't. Significant impact in both patient populations. Does it matter if you have very small stage 3A disease, or if you have, quote unquote, advanced stage 3C disease, according to AJCC 7 staging? You see, no, it doesn't, because you see that the hazard ratio, so the impact on the of the adjuvant therapy, is around 0.50 to 0.57 in the three groups. Obviously, it means that in the worst prognosis group, that reduction of relapses in absolute terms is the biggest. It's 22%, whereas in the most favorable group, it is about 11% in the stage 3A group. Is it the same in BRAF mutant patients versus BRAF wild type patients? Well, these are roughly 50 and 50% of the patient population. You see that the hazard ratio is most favorable in BRAF mutated patient population and a little bit less so in the BRAF wild type patient population. This finding, however, this benefit of 25% in the BRAF mutated patient population at 3 years is very comparable to the 20% rate difference that we observed in the COMBI-AD trial with the BRAF-MEK combo. Therefore, it means that BRAF mutant patients have a choice. They have the choice, will I do a BRAF-MEK combo adjuvant therapy, or will I take anti-PD-1 adjuvant therapy? Anti-PD-1 therapy seems to be at least as good. And so interestingly, when you compare the data from advanced disease and where you see that at 14 months, there is a crossover in the BRAF mutant patients that immunotherapy that is anti-PD-1 based, the top line is anti-PD-1 plus anti-CTLA-4, Nivopi trials. The bottom line here, the brown line, is anti-PD-1 monotherapy, crosses over with BRAF-MEK combo trials in BRAF mutant melanoma patients. And so what we see in advanced disease is that immunotherapy is in the lead and is in the end superior to the other options. So interestingly, in the adjuvant setting, we see the same type of crossover happening at 2 years, and we have demonstrated it to have happened at 3 years for anti-PD-1 versus or compared to a combination of dabrafenib plus trametinib. For pembro, it's 25% relapse-free survival benefit. For the COMBI-AD, it was 20%. So, in terms of tolerability, what's the picture? Well, for the anti-PD-1s, it's actually quite good in terms of discontinuation rates. In those trials, it was 14%, be it pembrolizumab or nivolumab. For the combination of dabrafenib plus trametinib, it was 26% over the year of BRAF-MEK combo therapy. For ipilimumab, high dose, it was very high, 53% discontinuation rate. When we look in detail to immune-related adverse events, we see that for all grades, it's about 35, 38%, and that it's actually low for grade 3, 4, 5 events. It is 7.5 to 8% in the Nivo and pembrolizumab trials. What we found in the pembrolizumab trial is what we published in Journal of in JAMA Oncology early 2020, and that we demonstrated that if you have immune-related adverse events in the pembrolizumab arm, you actually do significantly better in terms of you have a longer relapse-free survival period than if you don't have immune-related adverse events. So somehow it is a reflection of the tonus of your immune system. Does it translate into distant metastasis-free survival benefit? This is in press in Lancet Oncology. It will be published in about a month from now. So let's look at the consistency of the data. And here are the distant metastasis-free survival final analysis data of the Keynote 54 trial. And what it shows is it looks very similar to a relapse-free survival benefits. The hazard ratio is not 0.56, but it's 0.60 at this particular point in time. It also brings the consistent observation that for BRAF mutant patients, the benefit here is 20% at 3.5 years, 42 months. And for BRAF wild type, it's smaller, but it's still really significant. But this benefit of 25% is at least as good as the 20%. As the 20% benefit here for pembrolizumab is at least as good as the 14% benefit that was observed in the BRAF-MEK combo for BRAF mutated patients. So the next question then is, what is the translation of advanced disease into adjuvant in terms of the combination of Nivo-Ipi, right? We know that there is a numerical advantage of Nivo-Ipi in advanced disease over monotherapy with anti-PD-1 with Nivo alone in the Checkmate 67 trial. This translate into the same benefit combination versus nivolumab monotherapy in the Checkmate 915 trial. We haven't seen the results yet. Will be presented at AACR annual meeting this year, but we know from press releases that this trial failed to show a benefit of the combo over adjuvant nivolumab monotherapy. Interestingly, you see here a graph of a smaller trial, a randomized phase 2 trial that was conducted in Germany and published in The Lancet in 2020, the Immunet trial. And they did a separate trial only in the highest risk group for relapse, namely the resected stage 4 group. And in that group, they randomized nivolumab versus nivolumab-Ipi combo versus placebo. And so in that patient population where it's raining relapses, you see that anti-PD-1 plus anti-CTLA-4 Nivo-Ipi combo gives you the best results. It's the upper curve. The middle curve is monoadjuvant therapy with nivolumab alone, and the bottom curve is placebo. So that's where you see in the worst type of conditions still an indication of superiority of the combo over monotherapy. So then what is next? Well, what is next would be the rollout of these adjuvant therapies into what is still a patient population that has an appreciable relapse rate, and that's stage 2B/C. Their relapse rates are very comparable to stage 3AB intersection, whereas the stage 1-A patients have such a low relapse rate that only if you would introduce another tool to identify those patients who, in spite of a negative sentinel node, still will relapse, would be the candidates for adjuvant therapy. But without the use of such a diagnostic tool, it would be, vastly uncalled for and lead to overprescription of adjuvant therapy treatment. And so what do we know there? We know there that in the HACC 8th staging system, it shows that stage 1A and 1B have such a great prognosis that there's no adjuvant therapy scenario. This is stage 2A, but that still is an 88% survival at 10 years. And this is stage 2B and stage 2C, the black and the blue lower curves. Now, these two lower curves, you can argue that attrition rate is high enough to explore the benefits of adjuvant therapy, but for the stage 2A patients, 88% 10-year survival, that's a very hard case to make. So that would only be a case if you would identify those who will relapse in spite of being sentinel node negative. So do we have a way to do that? Well, for the stage 2BC melanoma patients, there are two adjuvant trials, one the Keynote 716 trial, one the Checkmate 76K trial for 1 year of anti-PD-1 therapy, randomized versus placebo. But for the introduction of stage 2A, there is a trial in Germany that will stratify patients by GEP, by a profiler, on the primary melanoma, and only if you have high risk score, then you can be randomized into Nivo versus observation. If you have low risk score, you can only enter the observation comparator control arm. The URTC will do a similar strategy for stage 2A, B, C together in a BRAF-MEK combo, encorafenib plus binimetinib versus placebo trial. There we will use the Skyline CPGP algorithm, that's the combination of clinical factors and profiler, to identify those who will relapse. And why do we think that's a good idea? Because on the Mayo Clinic's cohort of 754 patients, we identified this value of utilizing the CPGP. And if you have both sentinel node negative and a CPGP score that is negative or low risk, you will do very, very well in relapse-free survival. If you have a positive sentinel node plus a positive CPGP, which in that case actually will be always the case, you are on the purple curve. But if you are on the dark blue curve, you are on the curve of interest. These are patients who are stage 2 sentinel node negative patients, but who will still relapse at a rate of 30% at 5 years. And those patients have a relapse rate that is high enough to contemplate adjuvant therapy strategies. It translates in a similar observation for distant metastasis-free and overall survival. So that will be the further evolution in the adjuvant setting. But the real next revolution is the neoadjuvant immunotherapy revolution based on anti-PD-1 and mostly on the combination of anti-PD-1 plus anti-CTLA-4. And let's look at that story. So now, instead of doing surgery first and then treating an NED situation with adjuvant therapy, you now, before surgery, give your treatment, and then you will do surgery on what you hope will be a pathology complete or near complete or severely reduced disease. And that's how you will score your system. And so if you have palpable nodal disease, as you can see here in the bottom curve, you are excellent candidates for neoadjuvant exploration that was already demonstrated in mouse models to be superior to adjuvant approaches. So the first studies actually were with targeted therapy, with BRAF-MEK combos for BRAF mutant patients, because that is a treatment approach which has such high response rates and immediate response rates. So it seemed like the most attractive model. And so at the MD Anderson, they gave a BRAF-MEK combo for 8 weeks and then did their surgery, or they did the surgery up front. And you see that in standard of care treatment, you see multiple relapses, and that it's much better if you treat with neoadjuvant BRAF-MEK combo. However, you still see relapses. For distant metastasis-free survival, you see that if they had a pathologic complete response, you see very, very few relapses, if any. In Australia, they demonstrated roughly the same thing, but they demonstrated that even if you had pathologic complete responses, you did see relapses. If you had anything less than a pathologic complete response, you rapidly fell into your relapse pattern as if not much had happened with your preoperative neoadjuvant BRAF-MEK combos. So what happened then? Then there was an exploration of neoadjuvant anti-PD-1 monotherapy or neoadjuvant Nivopi treatment. So anti-PD-1 plus anti-CTLA-4. And in that initial pilot study, it was clear that you saw 25% pathologic complete responses with monotherapy, but you saw that in 73% with the combination. And so it was clear that in palpable nodal disease, the way to move forward would be with the combination. In Philadelphia, they looked at 1 dose of anti-PD-1 pembrolizumab prior to surgery, and they already saw a quite significant impact of doing that strategy, helping to avoid relapses by the combination of neoadjuvant anti-PD-1 and anti-PD-1 as monotherapy. But I think this figure is crucial to understand that the way forward is the combination of anti-PD-1 plus anti-CTLA-4 compared to just monotherapy with anti-PD-1. What happened at the National Cancer Institute in Amsterdam was that the pilot study in patients who had surgery first and then got anti-PD-1 adjuvant monotherapy. They scored for T-cell clone induction to already present antigens and to new antigens. And this is the pattern with adjuvant PD-1. The other group of patients received 2 cycles of anti-PD-1 plus anti-CTLA-4. So Ipi-Nivo, and then they had the surgery, and then they got 2 more cycles of Ipi-Nivo. And this is the blue pattern, demonstrating that both in diversity as well as in amplitude, that Ipi-Nivo combo was far superior to monotherapy with anti-PD-1. And this is the fundamental biologic basis why this is the way to go forward. Because what they demonstrated then further was, if you just look at the middle bar, that if you used low-dose Ipi, you gave 2 cycles of low-dose Ipi plus Nivo at 3 milligrams per kg every 3 weeks, 2 cycles, and you then did the surgery. Your grade 3-4 toxicity was around 20%. All patients were simply scheduled for surgery. Nobody did not undergo surgery, and there was a pathologic important response in 77% of patients. So that was taken forward because the other thing they found and demonstrated at ASCO 2020 was an update of the follow-up of these patients. And look at what happened here. In the green line, these are the patients who had a pathologic complete or near complete response. That means more than 90% necrosis. And that demonstrated that there were basically no relapses. There was only 1 patient that relapsed. The other patient died in a traffic accident and was no evidence of disease patient. If you don't have a pathologic complete or near complete response, then you just have your relapse pattern, as you can usually see it with pathologic palpable nodes in stage 3. So in Australia, they compared their experience with neoadjuvant immunotherapy compared to neoadjuvant targeted therapy. And it's very clear that the immunotherapy has superiority, because you see that if you have a pathologic complete or near complete response, you see basically no more relapses or extremely few relapses over the first 2 years. Whereas with the dabrafenib plus trametinib in just the BRAF mutant patient population, you see that even the pathologic complete responses don't protect you against relapses. And if you have anything less than a complete response, you see relapse patterns that are very disappointing. So the last observation then is, if you do this and you do administer 2 cycles of neoadjuvant Ipi-Nivo, you now ask the question, do I actually still need to do a therapeutic lymph node dissection if I have proven on my indicator node that I'm dealing with a pathologic complete or near complete response? Because we already know from the prior experience that we didn't see relapses at all anymore. So this trial gives 2 Ipi-Nivo induction cycles, then you do the indicator node resection. It's the only surgery you do. And if you have a complete response or near complete response, there is no complete lymph node dissection anymore. There's no adjuvant therapy, it's just follow-up. If you have a pathologic partial response, you do get a completion lymph node dissection. And there's further just follow-up. And if you have no response, no pathologic response, you know you're in big trouble. You get your completion lymph node dissection. You may also need radiation therapy, and you may get any adjuvant therapy that you choose. And so what did they demonstrate at ASCO 2020 after the first 100 patients had entered this product trial? Pathologic response rate confirmed above 70%. Grade 3, 4 immune-related adverse events around 20%. Therapeutic lymph node dissections omitted, avoided in 60% of patients. So this is a true revolution because it will lead to more cures and less surgery. And it's all developed in the first place in melanoma, palpable nodal stage 3 disease. Then it's also translated in bladder cancer, where you can have a 50% pathologic complete response rate with neoadjuvant anti-PD-1 therapy, and that leads to reduction of cystectomies. And in MSI colorectal cancer, there was actually 90 pathologic complete responses out of 20 patients who had MSI CRC, rectal cancers. And those patients were still operated. This was published in Nature Medicine 2020. But in the future, we are not going to operate anymore. It means no surgery, but it means endoscopy, biopsy, and MRI follow-up. And so we now have a whole flurry of trials in lung, head and neck, esophageal, gastric, breast, and even in glioblastoma multiforme. And so that's where the field is moving, and that's what I hope will give you a positioning to look at the cases and what are the opportunities for the patients with the disease presentations that you need to make decisions on. Thank you.
Dr. Egermont, thank you very much. That was an outstanding summary, and I think sets us up for the case discussions well. But before we move on to those, there were a few questions that came in. The first question from one of our viewers is, what are your thoughts on the emergence of PD-1 plus LAG-3 and PD-1 BEM-PEG regimens in stage 4 melanoma, and what will the implications be for how we use neoadjuvant or even adjuvant immunotherapy in the future?
Well, I can say something to it. Let's put forward, first of all, that the anti-PD-1 ceiling is already very hard to break. The anti-PD-1 plus anti-CTLA-4 ceiling is even harder to break. It's like the positive control for anything that we try at this particular point in time. So PD-1 plus LAG combo or PD-1 BEM-PEG combo regimens may be among the ones that could be interesting and yield similar results to anti-PD-1 plus anti-CTLA-4, but not necessarily better efficacy, but at the same time, it might come at less immune-related adverse events. And so the results of these trials will still be quite interesting in terms of whether one of those should move forward into the adjuvant setting based on the success story in the advanced setting.
Right, that's a great point. And, you know, interestingly, there are ongoing trials of PD-1 and LAG-3, including trials that are being run at MD Anderson along with Memorial Sloan Kettering. And so I think stay tuned. There will be some data presented at ASCO. And second question, are there any practices for scheduling surgeries or selecting adjuvant therapy you've adopted during the COVID-19 pandemic that you may retain even after?
Yeah, quite honestly, in the beginning, we didn't know what to do with the COVID-19 pandemic. We delayed quite a few treatments in the cancer arena. We're no longer doing that. We know that we can basically deal during the COVID pandemic with the treatments that we are providing, and that we should not delay, but we should actually schedule as we usually do.
Right.
It's a little bit different if you have doubt about the real benefit of a surgical or staging intervention or things like that. And so just to give you an example, we are using the CPGP now in the Netherlands to avoid patients to go into sentinel node staging if they have a thin melanoma and the CPGP is negative, because for that, we know you will only see 2 positive sentinel nodes out of 100 patients. So we prefer to keep them out of the hospital for those type of endeavors. But if it's dealing with effective treatments of cancer in stage 3-4 disease, then we just go ahead nowadays.
Great. Dr. Arian, any comments on that from Memorial Sloan Kettering?
No, I agree. I think, obviously beyond the testing for COVID, we're really trying to just move forward with the effective anti-cancer therapies and not delay for patients as well.
And I will bring up an interesting point. I think in the setting of vaccination, I think sometimes you can see adenopathy. I had a patient who came in with melanoma who had just had restaging and had massive axillary lymphadenopathy, and she was like, "Oh no, I just got my vaccine." And so I think you do have to take these things into consideration. But some interesting times, and I think it's pushed the hand to do neoadjuvant therapy in some cases where we otherwise may have gone straight to surgery, or at least in other centers. And I think we're just going to see more and more use of neoadjuvant strategies. And so with that, I think we can move on next to the case discussions. And so it's my great honor to really present Dr. Charlotte Arian from Memorial Sloan Kettering Cancer Center, who will lead us through these clinical consults and a case discussion on adjuvant and neoadjuvant immunotherapy in resectable melanoma. Charlotte?
Okay, great. Thank you for giving me the opportunity to present today, and I hope that this case discussion will be interactive and hopefully, bring home some of these other points that Dr. Egermont really excellently presented. So this first case is a case of a patient with stage 3A melanoma, a 45-year-old male with an extremity melanoma, 1.5 millimeter Clark floor with 1 mitosis without ulceration. He has no significant past medical history and a normal exam, so he underwent a wide excision and a sentinel node biopsy, which showed a positive sentinel node with a 2 millimeter deposit in an axillary lymph node. His BRAF testing showed that he was wild type. He did not have the V600E mutation, and his systemic imaging was normal. So he's stage 3A melanoma. So discussion really, just to summarize some of the data, is, should he have surveillance or adjuvant treatment, and what type of adjuvant treatment? So Dr. Egermont, do you want to just summarize what you would tell this patient about his risk of recurrence and how that could potentially be reduced or not with adjuvant therapy?
So from the data you provided, this is still a young patient, and he does not have autoimmune disease or kidney transplant. He has stage 3A disease, so he still has, good prognosis, but it's a stage 3A with a 2 millimeter metastatic deposit. So it's actually a stage 3A patient that we did have in our adjuvant trials represented, because there you needed to have a more than 1 millimeter deposit in your lymph node. He was BRAF wild type, so adjuvant BRAF MEK is of no use. So the question is, adjuvant anti-PD-1, yes or no? Well, the hazard ratio is 0.50 in stage 3A HACC7 classification. So you will reduce by 50% the risk of relapse. How big is that risk of relapse? It's not enormous, as we know. So roughly the relapse rate will be around 15 to 20% over 5 years. And so you will reduce that by, let's say, 5 to 8%, 5 to 10%. But this is a patient who has many years ahead of him. Adjuvant anti-PD-1 is tolerated very well. The only thing that you can get from anti-PD-1 is some endocrine, more or less chronic problems. There was an acute type 1 diabetes rate of 1% in pembrolizumab trial. So you need to inform him about these risks. The other grade 3-4 events are extremely rare. They're all below 1%, except for colitis, which always resolved. So At 45 years, most patients will say, yes, I think I will go ahead with that hazard ratio and that reduction of my relapse likelihood. So that's probably what would happen. If it would be a patient of 75 years older, the discussion would be different.
So I think you bring up a really important point about the relapse rate, which is seen both in your trials, but also in the Adjuvant BRAF-MEK trials. For stage 3A patients, the relapse rate is actually higher than what you would see when you would look at the survival for patients with stage 3A in the AJCC version 8, for example. And, one important component, I think, is that you guys selected out the highest risk patients for these trials. So having a millimeter of tumor burden is clinically significant as well. But also that maybe some of these people can be rescued in different ways. So if the patient just had small microscopic disease that just, was under a millimeter, would you treat then, or would you still say that that's your clinical decision point?
No, so basically you're on the sliding slope that the benefit is decreasing, and if there would be anything like autoimmune disease or those type of risk factors, then it really becomes a moot point, and I would certainly not push the patient into a decision to go for adjuvant therapy.
And Dr. Wargo at MD Anderson, would they treat the stage 3A with a millimeter tumor burden with immunotherapy, or is it?
Yeah, again, I think.
It's a relapse-free benefit. The survival benefit is less clear, I guess we could say at this point, right?
Right.
So.
Yeah, I think, and again, I think it would be a conversation, based on patient's age, comorbidities, presence of potential autoimmune conditions. It would definitely be a discussion. I think clearly with the higher burden of disease within the sentinel node, there would be more of a reason to treat or, really push it. But I think, with the lower burden, definitely not as much, there as far as potential benefit.
Right. So careful risk of both. I think here we are probably treating less people with stage 3A disease, but I certainly understand, the younger age and wanting to, patient understanding the potential side effects are important considerations.
Yeah, I think the message for the clinicians is don't push it. Mm-hmm. Don't push it. It's really because the risk-benefit ratio reaches 1 rather quickly. So, don't push it. Obviously, for stage 3BC, it's a very different discussion.
Great. Okay, so that's a perfect introduction to our next case of a stage 3B melanoma. This is a 67-year-old male with a melanoma, 3 millimeters, Clark 4, 1 mitosis, but no ulceration. He has a strange history of an ileitis, where he has had an anemia of unclear origin. He did have an endoscopy, a push endoscopy, where they were able to get into his distal ileum, and they had a biopsy that showed inflammation and ileitis, but not definitive for Crohn's. And he requires transfusions about every 6 months. Other than that, his exam is normal and no other significant past medical history. So he undergoes surgery with a wide excision and has a positive sentinel node, greater than 1 millimeter in size, and his systemic imaging is normal. So I'm going to, again, maybe go to Dr. Wargo this time and see. We didn't mention the BRAF status, but let's say that he has a BRAF mutation as well. So how would this patient be treated, or you think he should be treated?
Yeah, I think that's, definitely much higher risk of relapse. I think, again, with the ileitis, it's difficult to know. I think it does, raise the question that there could be autoimmunity associated, with treatment. And certainly there's patients who develop colitis and other autoimmunity on anti-PD-1. Nonetheless, if, that would certainly be a discussion to have with the patient. And I think, if they were BRAF wild type, talking about adjuvant anti-PD-1 albeit with a potentially higher risk of exacerbating the ileitis or any other autoimmunity, certainly could be. It could be an issue, but I think nonetheless worth discussing. I think, if the patient had a BRAF mutation, again, I think definitely a discussion of adjuvant BRAF/MEK would be very appropriate.
Dr. Egermont, would you have a preference on which treatment this person would get?
Yeah, it depends on the BRAF mutant status. In this case,
mutated.
Yeah, if he's mutated, I would offer primarily BRAF/MEK combo. But I would, in case of relapse and progression, then not withhold anti-PD-1 based therapy for the distant metastatic situation. But I would start it for the adjuvant setting in this case with a BRAF/MEK combo to avoid the ileitis discussion.
Yeah, and I think that's a lot of the discussion that we had here. Starting an immune therapy with a potential exacerbation of some autoimmune disease might make people, if the patient had a relapse in the future, might make people, less likely to want to use those medications. So maybe reserve that for relapse if you needed it, and use the BRAF/MEK as an adjuvant up front in this situation. But obviously, these are nuanced discussions with the patient. So, all right. Any other thoughts? I think we'll move on to This is clearly a patient who falls into the benefit side, though, for adjuvant therapy.
Yeah, definitely. And I think there are, strategies now that people are studying immune-related adverse events and ways to abrogate toxicity associated with therapy. I think there will be new things coming up that could be used in combination with immunotherapy, that will be of benefit in reducing toxicity.
Okay. Here's a patient with stage 3 disease, a 50-year-old woman with a melanoma of her shin, 6 millimeters, Clark 5 mitoses without ulceration, and no significant past medical history. Her exam is actually fairly normal, not clearly, large nodes that were palpable. But she underwent a PET scan because of her advanced disease, and it demonstrated 2 small groin nodes that were resectable, but definitely PET avid. No distant disease was noted, and biopsy was performed, was positive for melanoma, and she also had a BRAF mutation. So we've had a lot of discussion about this evolving area here. And so she's a stage 3C. She's resectable, but with clearly nodal disease and a high systemic, metastasis risk. So she could undergo surgery and have adjuvant PD-1 or adjuvant BRAF/MEK, which would be the second choice, or she could go neoadjuvant therapy with either immunotherapy, Ipi/Nivo, or neoadjuvant BRAF/MEK. So, Dr. Wargo, you guys have done a lot of neoadjuvant at MD Anderson. How would you want to treat this patient? Young,
right.
Healthy.
Yeah, exactly. And I think, mine and others' thinking on this has evolved. And certainly, we have ongoing clinical trials, which is, a great way to treat these patients. And so I think clinical trial, but then there's also opportunities to use either neoadjuvant BRAF/MEK inhibitors in this case, since she has a BRAF mutation, or anti-CTLA-4 and anti-PD-1. I will call out that data that was presented by Lex, that was a pooled analysis from the International Neoadjuvant Melanoma Consortia, really highlighting that if patients have anything less than a PAT CR with neoadjuvant BRAF/MEK, they really do have a pretty substantial risk of relapse. Whereas if you look at treatment with anti-CTLA-4 and anti-PD-1, even if they have, a partial response, they often have long-term benefits. So my feeling towards this has really shifted a bit. And, though both options are available, I personally would favor neoadjuvant anti-CTLA-4 and anti-PD-1 blockade in this patient.
So, Dr. Egermont, we have level 1 data, thanks, to you, that, adjuvant immune therapy really can improve survival and definitely relapse-free survival. But the data really is more immature with the neoadjuvant. But do you think it's convincing enough to proceed in the neoadjuvant setting in a patient like this?
Yeah, so anybody who has measurable lymph nodal positive disease, in my book now goes into anti-PD-1, anti-CTLA-4 combo neoadjuvant as the best option for cure. And it will speed up the clinical trial experience to make this happen as rapidly as possible for a twofold benefit. We will cure more people. We will do less surgery. So let's put it this way. It's almost too good to be true, but the data are what they are, and they are so far actually extremely convincing in the first couple of hundreds of patients treated this way. So I'm very hopeful that this revolution will pan out to be a major game changer of the management of, at first, palpable stage 3 disease, and of course also resectable stage 4 disease. But that's what I see happening. And any patients that I see that qualify for this, they go all to, well, the whole country here now is participating in this neoadjuvant effort.
Yeah, I think we saw this the same way as well, especially in a young, healthy person. And then I think it's important to recognize that you're not denying the patient the opportunity to get adjuvant therapy after surgery if they need it. And so, you're still, in many ways, still following the data from your trial. So this patient went on to receive 2 doses of Ipi-Nivo, and tolerated it fine, but complained of some fatigue, and so presented for her evaluation after the second dose. She had a PET scan that showed absolutely no change in the lymph node metastasis by size or in the amount of SUV uptake on the PET scan, but her TSH was normal and her TSH was 0 and her cortisol was 2. With a free T4 that was just under normal. So she's clearly having some endocrinopathy from her Ipi-Nivo. So next steps, no clear radiologic response. Should we delay surgery because of concern over adrenal insufficiency? Should we just go straight to surgery and do a completion lymph node dissection because she hasn't had a radiologic response? Or should we, again, both of these surgery options would, of course, involve treating the endocrinopathy, but remove just the only 2 enlarged nodes seen on imaging. So, Dr. Wargo, do you want to address this one first?
Sure. I think definitely addressing adrenal insufficiency is important, but I think that could be done relatively quickly. I think our approach here would be to do the complete lymph node dissection and get the additional data from pathologic evaluation of all the nodes. I think I would love, to embrace the resection of the index node. I think it needs to be done in the context of a clinical trial, and I'm super excited to get a Prado-like trial going here in the States, and would love for other surgeons to embrace that as well. But yeah, I think taking her to surgery after making sure that she's stable on the steroid replacement is perfectly appropriate for her.
Dr. Egermont?
Yeah, so we would have marked the largest node, right, with a marker. That would be the node that we would resect for pathologic evaluation. The PET scan will be later in terms of becoming negative than what you can see on pathologic evaluation of nodes. And so a complete response pathologically is weeks ahead of changes in the PET scan. That's basically how we would do it. And if it's near PCR or PCR, then we would leave it at that. If it's less than that, we will do the a completion lymph node dissection.
Yeah, I think it's important to recognize if you look at the recent summary of all the neoadjuvant trials, the radiologic response does not correlate well with pathologic response. However, if you look at the clinically meaningful responses, so in other words, if you look at the patients who had a CR on imaging, they had a CR on path. And if you look at a patient who progressed, majority of those were true progressions and very few of them were pseudo-progression. The hard patients are these patients, the patients who don't have any response at an early time point. And I think, Dr. Wargo, in your neoadjuvant trial, maybe you guys were looking at 6 weeks and some people are looking at 8 weeks. So they are early time points. So I think it's definitely not, definitive what's going on radiologically. As far as the marker, so you would mark and only take out that first node, even though there was another node.
Perhaps in this case, I would have taken out both enlarged nodes, but I would not have been surprised to find a near PCR, and I would then forego a completion lymph node dissection.
All right. Well, good. Well, we're going on to the next thing. So. Again, I wouldn't say that this is the standard of care yet. I think this was a lot of discussion with somebody who was young and healthy and wanted to potentially avoid the long-term side effects of a lymph node dissection. So this patient had resection of just the 2 nodes that were seen on the scan, which showed melanosis, necrosis, and no residual melanoma that they could identify by SOX staining, etc. So she's, a path CR or a near path CR with some endocrinopathy. And I will add that she went on, replacement levels of thyroid and less so of the adrenal. And both are actually, improved on their own a little bit. But she probably will be on some doses long term. So, would this person need adjuvant treatment? What do you think, Dr. Egermont?
Well, I think the early data seem to indicate that she may not. And given her immune-related adverse events, I would seriously consider not to give her adjuvant therapy because the likelihood that she was actually cured by 2 cycles of ipi-nivo is quite substantial.
Yeah, I agree. And it kind of brings up an important point that you were alluding to in the early trials, which is that patients who have toxicity may actually have more benefit from the treatment in the immunotherapy group, not in the targeted therapy group. And also the fact, that this, early look in immune therapy, just to reiterate this point, is much more prognostic than in the targeted therapy group, right? Dr. Wargo, I don't know if you want to comment again on that neoadjuvant BRAF-MEK trial, but a path CR does not necessarily translate as well into long-term benefit, right? Especially without neoadjuvant treatment.
Yeah, exactly. And, in our early trial and results that we published in Lancet Oncology, we saw a clear signal where path CR was a clear predictor, but then later on that pooled analysis, which was just published in Nature Medicine, it's pretty clear that only if you have a path CR, you do pretty well, but those patients still relapse on neoadjuvant BRAF-MEK, and if you have anything less than a complete pathologic response, you're at pretty high risk for relapse. But contrast that with immunotherapy, and most of those patients actually really do well.
So now this patient has a BRAF mutation. So if she had just a partial response on path, would you try to give her adjuvant treatment with PD-1, or would you switch her to BRAF-MEK?
I might consider BRAF-MEK, but anything better than that, I would keep her on anti-PD-1 because the long-term, benefit is just like in advanced disease. Immunotherapy is just so superior that you cannot deny that opportunity. If you say, well, I have immune-related adverse events that are so troublesome, I can actually only consider giving BRAF-MEK combo. You can do that, but then again, if in case they relapse later, they should simply get Ipi/Nivo.
I think that's an important point. Although troublesome and not great for a quality of life for a patient to have either hypophysitis or adrenal insufficiency or a thyroid, you can certainly retreat with immune therapy. This is, not a reason that you couldn't retreat, right? Do you guys agree with that?
Yeah. Absolutely.
Okay, this has been a great discussion, and we have one more case that Dr. Wargo is going to present, and so I will pass the slides over to her.
Great. Okay. Well, hopefully this will bring home a little bit of what we've already discussed and then bring in a new wrinkle, and that's a patient with acral melanoma. And so this is Alan, a 60-year-old lawyer who came in with melanoma of the left great toe. It measured at least 1.5 millimeters in thickness, 4 mitoses, no ulceration. He had no significant past medical history, and his exam was otherwise normal. He actually had an amputation of the toe with a sentinel lymph node biopsy and had actually a positive, 1 of 3 nodes positive. He was BRAF wild type, systemic imaging was normal, and was stage 3C. And so up for our treatment discussion, the next steps for Alan. So I'll turn it first to Charlotte. So how would you treat this patient with an acral melanoma and a positive sentinel node?
And he's BRAF wild type, right?
Correct.
Yeah. So, obviously he has a high risk of recurrence, stage 3C. Adjuvant PD-1 is what we would offer this patient. Obviously surveillance is always an option, but, understanding that with the acral melanoma, there is a lower response rate in stage 4 disease, but there's still a response rate. So, there still is a potential benefit. And I don't know, Dr. Eggermont, if you guys broke out in your adjuvant PD-1 by type and saw by histologic type a difference in response rate.
No, we did not.
But we would treat this patient with adjuvant PD-1.
So would we.
Yeah.
It's the only option basically that you have to offer. We know that overall in stage 3C, the benefit at 3 years, 3.5 years in terms of relapse-free survival is bigger than 25% in relapse rate difference, between 25 and 30%. I mean, that is just even if you are acral and it may be only half of that, it would still be worthwhile. So I think this is the only rational offer that you can make at this point in time.
Right. And I think that's important to highlight is that patients with acral and mucosal melanoma still do respond to immunotherapy. And so this patient did undergo treatment with adjuvant anti-PD-1. He was treated for 1 year with no evidence of relapse. He did develop thyroiditis and dermatitis. However, at 1 year post-op, he had multiple enlarged lymph nodes in the left groin with no distant disease, and biopsy showed metastatic melanoma. And so, Lex, at this point, I'll turn it over to you for the treatment discussion at this point.
Yeah, so at this point in time, the best response rates are obtained with the combination of anti-CTLA-4 plus PD-1. And so with the palpable nodal disease, you want to know, is he capable of responding? And can I, because it will actually matter for the further policy of managing the case. So I would absolutely go for neoadjuvant anti-CTLA-4, anti-PD-1 and take it from there.
Great. Even in the setting of the thyroiditis?
Yes. I don't care about thyroiditis.
Okay.
I'm sorry. I mean, we know how to handle that. And he has his last chance. And the last chance actually is anti-PD-1 plus anti-CTLA-4 at this point in time.
Yeah, and that's exactly what...
It's important to recognize, I think, that, if you extrapolate from the stage 4 data, his response rate will be less than what your standard neoadjuvant reported rates are.
Sure.
I agree with you. It's a great in vivo test for the patient to see this. But we know, first of all, that his response rate's a little bit less in because he was an ACRL, and then he showed us a failure rate. And so, this is someone who's getting into the arm of PD-1 resistance. And I think a lot of things that we would also consider here would be a clinical trial in, PD-1 resistant patients. He's clearly has resectable disease, but I agree with you. It's try to give him something to get a systemic response. There's no urgency to do surgery there.
Yeah. And so he was treated with neoadjuvant anti-PD-1 and anti-CTLA-4. He did develop, interestingly, cervical lymphadenopathy, for which we did a biopsy, and it just showed a sarcoid-like reaction with no melanoma. The disease in the groin was stable. He had a superficial and deep groin dissection, and pathology showed metastatic melanoma in 16 of 29 nodes in the superficial groin, 0 out of 13 in the deep. Postoperatively, he did develop a wound infection and required hospitalization and antibiotics. While he was in the hospital, actually developed hypophysitis and adrenal insufficiency, as well as an acute kidney injury, which was treated with steroids. And so now he underwent treatment with postoperative radiation. 3 months later, actually developed a nodule on his thigh, and biopsy revealed metastatic melanoma, but was treated with T-VEC with a complete response and remains in remission for 2 years now. He's on lifelong thyroid replacement and steroids, has normal kidney function. But I think this case does highlight that, we have a lot of tools in the toolbox these days, and I think you're going to use a lot of them in a patient like this. But ultimately, gosh, if someone like this can be alive and well years later, it's a real success story. Any final comments, Charlotte?
I think that this just highlights the fact, just as you were saying, that there are multiple options for these patients, and some in evolution, some injectable agents, some in clinical trials. And so I agree. We don't know the correct sequence of things at this point, but clearly there's lots of options, from systemic to local treatments. And as we move forward, it'll be best to identify the patients who we think will benefit and understand from each treatment.
Great. Thanks, Charlotte. Lex, anything to add?
No, this man is already more than 2 years later alive than he would have been 10 years ago. Mm-hmm. I mean, it demonstrates how effective actually Ipi/Nivo is. We would now see an increasing spectrum of options. At some point, you might also consider anti-PD-1 plus lenvatinib, for instance. And, there will be an expanding number of options to consider. But so far, you basically made all the right steps, and he came out of it, quite well.
Great. Okay. Well, so I did want to highlight this case inspired us actually to write this up, and we actually, for the Annals of Surgical Oncology, we put a paper together on toxicity of immune checkpoint inhibitors, considerations for the surgeon. And so really kind of refer those in the audience to that, should you have any questions. It's can be complicated and, can be tricky to manage these patients, but nonetheless, I think with the long-term benefit that we observe with treatment with immune checkpoint blockade, certainly worth the potential toxicity, and just learning how to manage it is really key. And so with that, I'd like to thank Dr. Arian, Dr. Egermont, and really thank all of you for your attention. And thank you very much, and have a great day.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/KNX860. This activity is supported through educational grants from Bristol Myers Squibb and Merck & Company Incorporated. This activity is accredited by Medical Learning Institute Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education.